Thank you. So as with previous speakers, when you're given a title by Bruce, you just accept it. So here you have it. Thank you for the invitation to speak. When you invite the Rolling Stones to perform in a large stadium show, you don't not give them a warm-up act. So I am here as Neil Rosen's warm-up act. And you are about to get an hour's worth of BRAF biology, and I'm going to lead with the considerations in the clinic in terms of sort of documenting the levels of success that we've had, at least in BRAF mutant melanoma, where we're by far further ahead than understanding the role of BRAF inhibitors in other BRAF mutated cancers, and then try to address the question of is more better. And first I'm going to pick that apart into the issue of whether we're done targeting the MAP kinase pathway in these tumors. In other words, have we achieved optimal MAP kinase pathway inhibition? And then trying to address that first, I'll move on to the topic of what are our other frontiers in terms of trying to develop combination targeted therapy regimens. So BRAF first appeared to us as a potential oncogene and therapeutic target back in 2002. Nearly all of what we know about BRAF mutant signaling and its therapeutic application of BRAF inhibitors is with this dominant entity. So this dominant entity here is demonstrated on this histogram, the V600 position mutations, which are the ones that have been best described as activating mutations that have about a 700 to 800-fold increased ability to phosphorylate MEK, the only known downstream substrate of BRAF. So in melanoma and elsewhere, that's been our focus, but an interesting area that I'm not going to touch upon today, but one that is going to emerge in the next year or two as being another, I think, very interesting discussion in terms of targeted therapy development will be these mutations that sit a good bit upstream in the kinase, which heretofore have been referred to as low-activity mutants. But some of the initial concerns in terms of BRAF being a therapeutic target, at least in melanoma, as opposed to other cancers in which BRAF mutations are found, comes from this type of data, which of course is much more recent than the BRAF mutation discovery. But nonetheless, analogous, I suppose, to small cell lung cancer with smoking-related mutations with melanocytes sitting in the periphery and exposed to UV, they suffer through an enormous amount of genetic alteration consequent to UV exposure. And BRAF mutation, of course, is just one of the needles in the haystack of just an enormous amount of somatic genetic change. Interestingly, though, despite the enormity of genetic alterations that accompany BRAF mutation, it still shines out as somewhat of a poor prognostic factor. Here, focusing on patients who have metastatic disease, you see patients with a BRAF mutation having a somewhat inferior outcome to patients who are BRAF wild type. This is in the era before the institution of BRAF targeted therapies. What's also interesting is that a full 40% of so-called BRAF wild-type tumors have NRAS mutations. If you pull them out of this top group, they also have quite a poor prognosis, in fact, maybe even a little worse than the BRAF mutant tumors, leaving then a group that actually has an even better prognosis if they are BRAF or NRAS wild-type. And this is still metastatic melanoma, so I don't want to overstate the point about having a quote-unquote good prognosis, but not as aggressive as the BRAF and NRAS mutants. As I'll turn back to a little bit later, BRAF mutations are accompanied commonly by genetic aberrations, commonly PTEN deletion, if not inactivating mutation, and in some instances AKT3 amplification as well. This is not an absolute relationship, but it's certainly the case that a healthy percentage of BRAF mutant tumors, you'll find these genetic aberrations. And then also overlying BRAF mutation quite commonly are P16 loss, cyclin D amplification, and CDK4 either amplification or activating mutation. And the field now, having really emphasized trying to nail down BRAF targeted therapy and MAP kinase pathway targeted therapy, is now looking towards these other axes, amongst others. But these are the genetic aberrations that, in fact, we knew about before BRAF mutations were first identified. So you wonder about their therapeutic relevance now in terms of developing combinations. Now, again, BRAF occurs in the midst of an absolute storm of genetic aberration, and even if you were to pick out the PTEN, AKT, and P16 axis alterations, you still wonder how many oncogenes and tumor suppressors do you need to add up to get a melanoma? And the answer seems to be, in fact, that BRAF mutation and PTEN loss here with the conditional expression of these alleles in melanocytes, so under a melanocyte promoter, exposure to tamoxifen, then locking in these mutations, specifically in melanocytes, you get an enormous burden of cutaneous melanoma and, in fact, some invasive an apparently metastatic melanoma. This apparent survival curve here showing you the power of this BRAF-P10 interaction is actually the animals being sacrificed because of largely superficial burden of disease, but nonetheless, by all accounts, looks like melanoma. Crossing BRAF with P16 inactivation will accelerate the formation of melanomas beyond just BRAF itself, but clearly not as powerful an impact as the BRAF-P10 combination. Nonetheless, it would suggest at least that these long known about concomitant genetic alterations do likely play an important biologic role, and we'll, of course, now consider their potential therapeutic significance in a moment. So the first point that I've preached about for the past couple of years, but I've been sort of softening my preaching a little bit with the crizotinib development story, is that I would say that with sorafenib, we had hopes that this drug that was prospectively developed as a RAF inhibitor in the late 90s and entered clinical development with a apparently clean cross-reactivity profile against a grand total of 13 additional kinases, which was, I suppose, about the industry standard in the year 2000 when kinase inhibitors were being brought forward initially. Turns out when you profile this thing a bit more broadly, you find that it actually touches a good bit of the kinome, and most powerfully the receptor tyrosine kinase domain. BRAF sits up here in the upper right-hand corner. So it is a RAF inhibitor, but the problem is that other quote-unquote competing off-target effects potentially would limit its utility as a RAF inhibitor. We knew some of this now by the time 2002 had dawned, even though this data, the full profile didn't exist for a few more years later. It was already emerging in 2002, in fact, that it was at least a VEGF receptor, PDGF receptor inhibitor. So you wonder with a drug of this sort whether you can possibly escalate the dose and achieve concentrations in patients that are tolerable that might deliver enough of an anti-BRAF effect. It was the only agent we had in 2002. That was a putative RAF inhibitor, and we had to wait almost 4 years for the first prospectively developed selective BRAF inhibitor, here referred to as PLX4032 and now known as Vemurafenib. And the short answer I'll come to in just a moment, but one of the observations that we've been able to make just recently with the selective BRAF inhibitors is that they will not only arrest cell cycle selectively in tumors that are BRAF mutant here versus BRAF wild type, but also induce apoptosis selectively. Sorry for the dropout of the M here. But sorafenib had never shown that type of selectivity, at least in cell culture, and even in xenografts for that matter. It was a drug that seemed to demonstrate some degree of growth inhibition, but just not in a selective fashion based on the presence or absence of the BRAF mutation. Notably, siRNA data look more like this. If you knock down BRAF, it appears that only BRAF mutant tumors care about that. But the real critical observation, I think, came in the clinical studies where we first treated patients in a big rush, frankly, over a few weeks period of time, enrolled an entire phase 2 protocol between ourselves at that point at the University of Pennsylvania and Royal Marsden, and really didn't take the time to do tumor biopsies in that rapid assessment looking for efficacy. We didn't see efficacy. We had one transient response amongst 39 patients. But we circled back and did a window study. Sorafenib with chemotherapy was looking modestly active, or moderately active, I suppose, at the time, in melanoma. So we circled back and did a window study where we gave patients single-agent sorafenib who had biopsyable disease, and then after a 4-week period of time added the chemotherapy. But that data generated a few months after the single-agent data showing lack of efficacy offered a potential explanation, which is to say that while there was evidence of pathway inhibition at the level of phospho work, it was certainly modest. I mean, no one would have made an argument that 20 to 40% inhibition of the pathway at the level of ERK phosphorylation would be expected to be efficacious. Now, to be honest, we didn't know exactly how much we needed, but this certainly looked to be potentially inadequate and kept the door open for the role of a more selective agent. So this is the degree of pathway inhibition we're able to achieve with PLX4032 at its maximum tolerated dose in a cohort of patients who were biopsied once we had established what the maximum tolerated dose was. And you see here much more profound evidence of pathway inhibition, and I wouldn't say uniform, but nearly so when you look at the tight clustering here of the day 15 biopsy result. So a more selective agent allowed us to deliver a dose and exposure that offered much more anti-MAP kinase pathway effect. And you could say, well, look, there's really not that much room for improvement here. You can't really expect an agent to be able to achieve 100% inhibition, and that, of course, is a point I'll turn to. And you could say, I suppose, that the clinical data would suggest there probably isn't much room for improvement, because we wouldn't have much reason to think that we could do better than that molecular evidence, this early PET scan evidence, or the tumor regression data, which I think line up quite nicely in comparison to EGFR targeting and EGFR mutant lung, ALK targeting for that matter as well, where the so-called waterfall plots look very much like this. You see the vast majority of patients with some degree of tumor regression, a few patients with complete responses, and this result scaled up perfectly well whether you quadrupled the number of patients in phase 2 or went to tenfold the number of patients in phase 3, the same exact profile of response. And so you could say, well, check the box. We're inhibiting BRAF as well as you can or should. And now let's move on to the other pathways that are of relevance. Well, not so fast. Turns out when you look at the benefit of this agent in terms of overall survival, it clearly shines through compared to our long-standing placebo-like agent, dacarbazine. So yes, it improves survival compared to dacarbazine. Notice the short time scale here in terms of follow-up. This result, the curves had diverged so early and so powerfully that the trial was stopped 1 month after the last patient was accrued, and it only took 12 months to accrue this trial. So it was quite immature data. But you notice, even with this early immature result, that the protection from fatality is quite short-lived, and you start to lose patients thereafter at a progressive rate. And I'll come back to the issue of how to try to think about improving on toxicity in a moment, on efficacy in a moment, but here focusing on toxicity, we do produce some toxicities with this agent when we escalate the exposure to what we think is the maximum that patients can put up with chronic dosing. The exact mechanism of these toxicities always difficult to discern, but some of it certainly could be RAF related. But this one showed up early, even in phase 1 clinical development, as a curious observation. The appearance of cutaneous squamous cell carcinomas, but more commonly their non-invasive and very well differentiated counterpart, keratoacanthoma, in about a quarter of the patients treated. And this rate has held up in phase 2 and phase 3 trials, not just in phase 1. And these are very early events. They happen within the first few weeks of dosing, usually, and they're oftentimes single events. Patients will have a single proliferative lesion appear, and they'll have that excised, continue on therapy, and generally not have more, but there are some stragglers, as you can see out here. And this would speak to the drug having an effect probably on a cell that is predisposed to grow, if you will. Although I will tell you that in just about every case, we and other investigators could not discern a true precursor lesion, so something visible at that site. But by precursor, I mean just something at the cellular level, not actually a benign tumor yet. Turns out a couple decades before, it had been described that HRAS mutations can be found in a subset of keratoacanthomas and squamous cell carcinomas. And we thought this was interesting only when Neil Rosen and other colleagues corroborated a very intriguing observation, which you're about to hear a good bit more about. And that is that BRAF inhibitors will certainly block the MAP kinase pathway to a fair degree in the context of a BRAF mutation. But in RAS mutant cells, and some others as well, but particularly RAS mutant cells, they will actually activate the pathway. And I'm hinting as to what the explanation is here, but I'm going to let Neil detail that a good bit more. But this quote-unquote paradoxical effect, where an expected inhibitor inhibits in tumor cells, or at least in one kind of tumor cell, but not in another, has recently been linked quite nicely, even in an animal model, to the human observation. I should mention that when we've biopsied those keratoacanthomas from patients and taken them to the lab and sequenced their RAS genes, as is about to be published, the vast majority of them have HRAS mutations. So whereas the minority of sporadic cases do, the vast majority of the ones that appear on these patients do. So we think, in fact, we are enriching or selecting for these RAS mutant precursors. That's going to be a point that I will circle back to in a moment, but let me go back to the issue of efficacy. So as I alluded to with the survival data, here focusing on disease control, duration of response / progression-free survival, what you see in the initial cohort of patients that we treated with PLX4032 and all of the subsequent cohorts as well is this spectrum where patients are very likely to have an objective response, as denoted by the gray diamond, and those usually happen very early in the course of treatment, although some are a little delayed in onset. But what you see is a cohort or a sub-cohort of patients who have very, very short-lived responses. So this is where I think Engelman and others rightly pick on us in the BRAF mutant field for having an impressive early effect, but not even quite as durable as ALK and EGFR targeting. And I would say we were really at a bit of a loss for why it would be that we would see such short-lived responses in a notable proportion of patients. And this type of, let's say, 1/3 of responding patients having very, very short-lived responses has continued to hold up in larger clinical investigations. Certainly, there are patients who have more meaningful durations of response. And in fact, out of this cohort, 7 of these patients have gone 2 years and still going in terms of response to therapy. So there's quite a heterogeneity in terms of response. And I would posit to you, as Neil elucidates mechanisms of resistance, that there may be mechanisms that play differently in this very, very early occurrence of resistance versus the much later occurrence of resistance. So just bear that in mind as you hear more about the molecular underpinnings. So in terms of improving on single-agent BRAF inhibition, the first question one could ask, again, is have we maxed out on BRAF inhibition and MAP kinase pathway inhibition? I'll show you one example that fits into the data that I've shown you before on the rather marked degree of MAP kinase pathway inhibition at the level of ERK phosphorylation early in the course of treatment with MTD dosing of PLX432. However, you can always find in a day 15 tumor biopsy that there are some residual ERK-positive cells. And the significance of this in terms of maintaining their survival and ultimately mediating resistance of course, was not established just with these simple observations, but you will always find some degree of residual activation. I'll just denote here before I leave it that this little ribbon of cells are endothelial cells that are showing you very marked ERK phosphorylation, which we think relates to the activation phenomenon that can occur in some tissues that lack a BRAF mutation, in this case, endothelial cells. You can model this notion of residual MAP kinase pathway activity even in vitro. So while you could try to make arguments about heterogeneity in the tumor microenvironment and the drug maybe not penetrating very well, in fact, you can't make that statement in three-dimensional culture where you crank up the dose of a selected BRAF inhibitor and you still see viable tumor cells here with the red core being cells that are undergoing apoptosis. But again, no matter how high you take the concentration of the drug, even in vitro, you'll still see this. And when you plate those cells, grow them in 2 dimensions, do the same thing, you'll see that nuclear phospho-ERK will still persist even at very high concentrations of the drug. So again, is this meaningful? Is this a mechanism by which these surviving cells are hibernating and potentially could use this residual pathway activity to drive ultimate emergence of clinical resistance? We think so. You can show in the same system here in vitro that if you add a MEK inhibitor to escalating doses of the BRAF inhibitor, having the MEK inhibitor on board will actually shift by about tenfold the sensitivity of these cells at the level of PARP cleavage or caspase cleavage as well. So suggesting, in fact, that trying to mop up some of this residual MAP kinase pathway activity with a MEK inhibitor may be one way to try to overcome it. And here's the flow data showing you, again, this shift approximately tenfold in terms of the sub-G1 fraction, and whereas cell cycle arrest perhaps not so powerfully influenced. So how might we try to translate this in terms of clinical development? Well, there are a long list of MEK inhibitors. I stopped at 5, but you could go many more than this that have been in the clinic. Several of them now have been used to treat at least a few BRAF mutant melanoma patients to credential them as legitimate MEK inhibitors that have activity in that setting. You notice here that 2 of the compounds are from one company, and so GSK was the first to be able to execute on a clinical trial to try to test the concept that BRAF inhibition combined with MEK inhibition might be able to overcome some degree of the resistance that we were observing. Preclinically, in vitro, you can show evidence that the combo looks more active. This is, again, those 2 agents from GSK, the BRAF and the MEK inhibitor. I should comment that this BRAF inhibitor is as selective as PLX432 and, in fact, a bit more potent. And this scales actually in vivo. So at what appear to be tolerable doses in the xenograft, you can show that this same cell line now transplanted into the mouse, you get a deeper response and a more durable response with the combination of the 2 drugs when each are being given at their sort of working doses, if you will, in the animal models. So this was the simple result that we were trying to translate into the clinic. The BRAF inhibitor has activity that's very comparable to PLX432. The MEK inhibitor, just showing you, has its own activity with partial and complete responses in the majority of patients, but well, regression, I should say, in the majority of patients. And while you might say this doesn't look quite as good as a BRAF inhibitor, and that may be the case, in fact, disease control in this same small cohort of BRAF mutant patients looked very, very comparable to the BRAF inhibitor overall. Not better, but very comparable. So the combination of the BRAF inhibitor and the MEK inhibitor required a phase 1 study. We weren't sure if we could truly safely deliver both drugs, whether there might be pharmacokinetic drug-drug interaction. So we escalated the dose of both drugs. Much to our surprise, it turned out to be very easy to do that. We were able to get to full doses of the drug very readily. We then explored activity in a small, but now double the size of this, cohort of BRAF inhibitor refractory patients. Saw some degree of activity. You might wonder how much the MEK inhibitor itself might have offered. And in fact, this MEK inhibitor produced no responses and very little disease stabilization when evaluated in a separate trial. Retreatment with this BRAF inhibitor in patients who had had PLX432, we wouldn't expect to be very active, but of course that wasn't formally tested. So some activity here, but it's really down here where we were focusing our attention. And we saw as we increased the dose of both drugs, so even when we weren't giving quote-unquote full doses of each agent, that we still had a complete response rate that appeared favorable compared to our experience with single-agent BRAF, this agent as well as PLX432, an overall response rate that was quite high and an overall disease control rate that was quite high. If you focus just in on the small cohort of patients who received full doses of both drugs, again, you see a complete and partial response rate that now looks superior, albeit a small number of patients, than our experience with BRAF inhibition alone and a complete early disease control. So even there, a marginal improvement on our experience with single-agent BRAF inhibition. This has now been scaled up to a 150-patient randomized phase 2 study where we've treated patients with full-dose BRAF and MEK versus single-agent BRAF. And while we've completed that accrual, and Harvard is the lead site of this study, don't have the data from the entire study yet to update, but what I would say is that we've now markedly increased this number of patients treated. These types of results have held up quite nicely. What we also aim to see, of course, is whether we're maintaining the durability of the responses in a way that's superior to single-agent BRAF inhibition, and we'll have that result actually within the next few weeks, we hope, and certainly we'll present it no later than ASCO of next year. What's also very intriguing, and as you might have guessed from the comments that I preliminarily laid out before, the addition of the MEK inhibitor actually seems to block the formation of these cutaneous squamous cell carcinomas and keratoacanthomas. So when I say less than 1%, in fact, with now a very large number of patients treated as a single case versus the rate that's been seen in many other studies with single-agent BRAF inhibition with this BRAF inhibitor, but PLX432, in fact, has about a 25% rate of these lesions appearing. So the addition of the MEK inhibitor at least has that beneficial consequence. What's very interesting is that beyond that observation, there's also just less toxicity overall. The combination ends up being easier for patients to take than either drug alone at their full doses. So that would suggest, but doesn't prove, that some of the BRAF-related toxicities may actually be related to pathway upregulation, not inhibition. MEK inhibitors are thought to inhibit the pathway somewhat independent of genetic context, and so could block it in the tumor as well as in normal tissue. So in terms of trying to further explore this concept, a two-drug combination might be optimal. However, it may be possible that there's room for improvement even with more potent and more selective BRAF inhibitors, and we've just taken one that looks like that from Novartis into phase 1 development, so very early days. But we'll be looking to see if this can accomplish what the two-drug combo can, at least in terms of efficacy. And the first in-human ERK inhibitor also entering phase 1 development right now in our group is the other hope in terms of trying to achieve some of what the BRAF-MEK combo is able to do in one drug. It may also be an important additional point of intervention that Neil might touch upon in his comments. So the notion of maximizing MAPK pathway inhibition, we learned in the early days, going from sorafenib to a more selective agent, we need to be at least above 80% pathway inhibition using semi-quantitative metrics to see efficacy. However, even when we give MTD dosing of these drugs, we still see residual pathway activity. And before then reaching out to the well-known overlapping genetically altered pathways, I think we need to optimize our targeting of this pathway. So I think for the sake of time, I will stop there and pass the baton to Neil. Thank you.
So we have time for questions. Let me start with one in terms of, unlike lung cancer, you do diagnose melanoma early with a chance of relapse. Is there much activity in terms of adjuvant treatments?
So we're starting the first adjuvant trial with single-agent BRAF inhibition with PLX432 in probably about 2 or 3 months. Will be the first study in a high-risk resected population. and fingers crossed that we'll actually be able to potentially eradicate microscopic residual disease, or at least hopefully suppress it for a period of time. And of course, the other discussion that's a matter of focus right now, given the emergence of these BRAF-MEK data, with a little bit more time and maturity, might that be an even better adjuvant approach to take? And discussions are underway about that concept as well. So we may end up producing results with single-agent BRAF inhibition in the adjuvant setting, and then in parallel, BRAF-MEK.
Other questions?
I was curious if you have any information yet about resistance as far as the combination. Are you seeing anything there as far as differences with each agent alone?
Yeah, great question. So I deleted all of my usual resistance slides when I saw that Neil was going to be speaking after me, particularly given the title of his talk. So he'll touch upon that. But no, it's a little early. We are, of course, as we've always been focused on getting tumor biopsies before treatment and at resistance on single-agent BRAF inhibition. We're doing the same with BRAF-MEK. We actually haven't analyzed those samples yet. We're still accumulating the numbers. That trial has been ongoing, just over these past few months. So we need some number of months to pass to actually just accumulate enough progressing patients to have the raw material. But you can be sure we'll be collaborating with Neil on trying to understand what drives those tumors.
Bruce?
In that slide on the duration of response, what struck me was that everybody that was beyond a year was still responding.
Right.
And everybody that, and all the short responders, obviously, had been, the ones that now had been resistant or became resistant were all 6 months, 5 months, 4 months.
Right. You don't lose a lot of patients in the gap. It's true. So up through 9 months, let's say, there's a distribution that looks somewhat normal in terms of the progressing events, although a little skewed, I suppose, to that early cluster. But then you actually see a tail emerge where not a lot is happening for a bit longer. So those who made it to 18 months were very likely to make it to 24 months and counting. Now that's going back. The only trial old enough to make those statements still is the phase 1 expansion cohort. Phase 2 study, of course, has been completed and those patients continue to be followed. The phase 3 trial was conducted essentially in parallel. So we're about to have a much larger cohort of patients to try to define the distribution, but then I think most importantly as we look at mechanisms of resistance to try to bucket them, to look at the issue of whether there's different mechanisms.
Also, is there something up front that you can see in there?
Oh, predictive markers. Oh, no, of course, right. And there we have samples to inform those analyses in a significantly larger percentage of patients than we have these paired biopsies. And so, no, exactly right. Trying to hunt for predictive markers to discern those outcomes would be critical.
Marty?
You're a great lounge act for Frank Sinatra. Keith, have you seen in those that have developed resistance, even on the single BRAF inhibition, any change in the V600E?
So Neil will again delve into those issues, but it's an important preface point to make before Neil dives in, which is no, we've screened for that now in dozens and dozens of cases, and not just at Harvard, but the other centers that were early investigators with this agent. And we never see in the kinase domain mutations that you'd predict to be resistance mutations. So it's not following that example. I deleted all those slides to leave it for Neil, but he'll describe the complexity of what seems to be going on.
And Keith, have you tried the recipe of treatment and then a gap of treatment and retreating?
Yeah, it's anecdotally been tried in a few cases. You can imagine we're not very tempted in patients who've had really sort of frightening progression of disease in terms of pace or number of lesions. But we do have a fair number of patients who have 10 lesions regress and only 1 or 2, a few progress, and at a rate that's not very intimidating. And that has been done with short interval off therapy in a couple of instances, and supposedly at least disease control was regained, if you will. But it hasn't been done in earnest. And since we're not seeing resistance mutations in BRAF itself, it's certainly an important point that there might be epigenetic mechanisms that could, quote-unquote, reset.
Great. Thanks very much, Keith.